Hi, my name's Dr. Stuart Kilner, and today we're just going to run through a little bit on sort of basics of bone biology, give you an idea and an understanding of what's going on when we use the material, and really why we choose this material over different or other materials. So beginning off, starting with something that isn't dentally relevant, we're looking at a newt. Why are we looking at a newt? Well, this animal has just about the best regenerative potential of any animal that we know of. We all know that it can lose an arm and regrow an arm over a certain period of time, but more interestingly, it can actually lose any organ and completely regrow any organ as needed. So the regenerative potential there is huge. Now, looking more to ourselves, we do have a regenerative potential, but it's limited. We can sort of have a small scratch or a small wound, and it can sort of grow back and eventually look relatively unscathed. Although, if we were to lose any more than that, we'd be leaving a scar and a defect area as well. So when we consider bone grafting and what we're doing and how we're using different materials, we also need to think about the words and things that we're using as well. We often use these words interchangeably, although they all represent slightly different things. So bone graft is defined as a piece of living tissue that is transplanted surgically. So often we use bone graft, but really it's not totally accurate when we're talking about augmenting or regenerating with bone materials. Or augmenting as well, the action of process of making or becoming greater in size. So there are some materials that we use where we are augmenting, we're making something bigger in size. And then when it comes to the materials that we're using specifically, we like to use the word regeneration because it's the process of growing new tissue. And that's where having a material that's totally sort of resorptive, i.e. turns over, disappears and lets the body grow into that site is an advantage and a benefit. So when we clinically look at this sort of regeneration and interaction with the bone, we can see here's a site that has a defect. Relatively large defect, infected tooth, and this is following a normal sort of socket preservation protocol. This is a case that we've documented and shown in the socket preservation webinar. But you can see just on the right here, that's where we've added some of the EthOss. So added a small amount of material, not trying to get too much out of this, just trying to improve the outcome. So the material here is basically just helping encouraging the site to heal a little better than it would have done without any EthOss. And here we can see 12 weeks later a site which is ready for us to use or place an implant and follow a relatively normal protocol of placing an implant, possibly with a small internal lift, but you can see that's a far easier job than it perhaps would have been had we just left the site with nothing. So what are the sort of clinical implications of this? Well, it means that we can regenerate areas like this, allowing us to sort of recreate that buccal contour with sort of true host vital bone underneath. Cases like this as well, where we've got a really nice outcome with sort of limited and minimal intervention. And again, cases like this where the outcome benefits the patient and it benefits us because it's as close to what it would have been like having teeth there, where we've sort of regenerated that sort of buccal contour around the teeth as well. So in order for us to sort of plan for what's going to happen, we need to look at what's going on in and around bone, and this is a really nice slide because actually it shows us the sort of total view and complete picture of bone remodeling, where we've got this sort of on the left hand side activation, middle resorption, and then further over to the right the sort of formation sequence. So this gives us a total view of what's going on in one picture. And we've got the osteoclasts working on the left here. They are resorbing the bone, moving over onto the preosteoblasts, where we've got the enzymes that are being secreted that are doing something similar, onto the osteoblasts that you can see up in this histological slide, and then moving on to the sort of cementation zone where you've got osteocytes cemented in. Now we've got to remember that bone is a living tissue, so mineralized connective tissue which is dynamic and turning over. On average, approximately sort of every 200 days, bone cells are going through that cycle that we just showed. So Julius Wolff documented a law in which healthy bones will adapt and change to the stress that it is subject to. This law is one of the reasons why I have a preference for using non-splintered crowns, among others, but it's nice to see these implants sitting in bone that appears to have osteocondensed over a period of 26 years, of which they've been in function. So we know as well, non-clinically, astronauts that go into space, because of the reduced stress and strain on their body, they have to spend a lot of time exercising to try and maintain their bone mineral density. So we know that's on one end of the spectrum. Here, where we're not using bone, you can see areas of a hip replacement that haven't been exposed to any stress or strain are resorbing over time. So this is evidence of Wolff's law from an orthopedic point of view, and that phenomenon is called stress shielding, where reduced bone around a point of sort of limited stress and strain. So we know that bone is this mineralized connective tissue which has the capacity to look after us, but if you don't use it, you lose it. So it starts to go less dense. An example of that is when we take teeth out and we lose bone in terms of height and width. And if we look at this extraction site over a period of 6 months, you can see we've lost a reasonable amount of height and a reasonable amount of width. So the other thing as well is when we're interpreting these radiographs, and we're looking and trying to understand or estimate where bone is, or where healthy bone is, it was interesting to sort of come across this case, or unfortunate but interesting to come across this case of Mronge, where clinically you can see we've got a huge area of sort of affected bone which clearly isn't healthy or vital or bleeding, but in the radiograph that we take at the same time we see this sort of mineralized area of bone that actually looks, for all intents and purposes, all right. We look at that radiograph and without seeing the clinical picture we wouldn't be able to assume that anything was wrong. So sometimes when we're looking at radiographs we have to remember that it is just a interpretation of a projected 2D image, and we've got no idea how vital or healthy that bone is in there without looking at histological slides.